I dread each night, I fear what I remember. The pain settles in and my eyes feel heavy. Propped up in an upright position, sleep seems unfathomable. In a plushy, comfortable bed, in the most uncomfortable position. Pills to help the pain, drugs to calm the muscles. I float above my body and I realize I'm miserable. My tired, heavy eyes burn as the tears trickle. I let them cascade down my cheeks because I know it's a cycle. Every night it repeats. Every night I'm miserable. Post-traumatic stress disorder is classified as a trauma and stressor-related disorder that occurs in direct response to a traumatic event. A traumatic event is any event in which there is actual or threatened death, serious injury, or sexual violence. Such events can be direct through experience or witnessing, or indirect through learning or repeated exposure to detail. Currently, in the U.S., PTSD affects 7 to 8% of adults in their lifetime and 8 million adults every year. Women are more than twice as likely to develop PTSD as men. Veterans are a subgroup of the population especially vulnerable to PTSD. Due to the chronic nature of the disease and the high comorbidities, PTSD has a significant economic and social burden. Having symptoms of distress following a traumatic event is completely normal, but it is the intensity and duration of these symptoms that distinguish a typical reaction from a deviant one. When such symptoms occur only in the first month following a trauma, it is classified as acute stress disorder. To be diagnosed with PTSD, symptoms must be present longer than a month. The Diagnostic and Statistics Manual groups symptoms into categories and employs a polythetic approach to diagnosis. A person with PTSD must exhibit at least one intrusion symptom, consistent and intentional avoidance of trauma-related thoughts, feelings, and/or external stimuli, at least 2 changes in cognitions and mood, and at least 2 changes in arousal and reactivity. Flashbacks differ from memories in that when experiencing a flashback, the person re-experiences the event as if they are living it again. 70% of adults have experienced at least one traumatic event in their lives. If simply experiencing trauma was enough to trigger PTSD, then the prevalence would be 10 times what it actually is, meaning that there must be other factors contributing to the development of PTSD. Certain psychological qualities can make a person more likely to develop PTSD in response to a traumatic event. These surround the ways in which the person thinks about themselves and the world and how they process events and attribute causality. These cognitive schema are learned in childhood and are carried with a person throughout their life. An important schema for PTSD is one of self-attributions. Certain personality traits and maladaptive coping skills also increase the risk of PTSD. Another risk factor is a history of behavioral or psychological problems, which could be indicative of poor coping skills in general. A person's underlying biology plays a crucial role in the development of PTSD. When a trauma occurs, stress causes changes in the brain's chemical regulation. The hypothalamic pituitary adrenal, or HPA axis, is the body's primary stress response system. The HPA axis is regulated by genes such as corticotrophin-releasing hormone type 1 receptor gene. Amstatter et al. Looked at single nucleotide polymorphisms in that gene and found that one such genetic marker was significantly related to PTSD symptoms and their trajectory over time. Furthermore, Sweden et al. Showed that glucocorticoid receptor, the receptor to which corticotrophin-releasing hormones bind to, occurred in higher levels in subjects who later developed PTSD. Another important structure is the hippocampus, which is associated primarily with emotion and memory. Smaller hippocampal volume has been observed in patients with PTSD. In a controlled study that compared veterans with PTSD to both veterans and non-veterans without PTSD, Ruiz et al. Showed that smaller left hippocampal volume is not a result of trauma and does not increase after successful treatment, validating it as a risk factor. Underlying biology, genes play an important role in determining the development of PTSD. Those whose families have a history of anxiety, trauma, and PTSD are more likely to develop the disorder. However, this family correlation is not enough to say that genes unto themselves are responsible. Rather, risk could stem from a family's shared environment. Environmental factors germane to PTSD include life stressors that weaken a person's ability to cope with larger traumas, and family setting with a lack of support in which non-effective coping strategies and low self-confidence are learned. Beck et al. Show that even something like unemployment increases the likelihood of developing PTSD. A twin study by Stein et al. Showed how both environment and genes are relevant to PTSD. PTSD associated with assaultive trauma is in part due to a genetic makeup that predisposed people to high-risk settings, while PTSD associated with non-assaultive trauma is best explained by environmental influences. Lastly, the specific nature of a trauma can precipitate the development of PTSD. Not surprisingly, the more severe a trauma is, the more likely it is that PTSD will develop. PTSD resulting from less severe traumas has a greater contribution from personal vulnerabilities. Proximity to trauma is also relevant. In a study of children following a fatal sniper attack at their elementary school, Pinus et al. Showed a notable correlation between the proximity of a child to the violence and the number of PTSD symptoms they expressed. Additionally, disassociation during trauma is a very strong predictor of developing PTSD. Specific traumas are associated with different estimated risks, with rape, physical assault, and other sexual assault among the highest. There are many factors that become relevant after a trauma has occurred and function to maintain PTSD. Biologically, deregulation of GABA and glutaminergic pathways and the long-term synaptic changes which translate experiences into memories create abnormal, exaggerated, and ingrained memory encoding. This explains the continued re-experiencing and flashbacks that perpetuate stress and anxiety around trauma-related stimuli. Psychological factors also contribute to maintenance. The most critical protective factor against PTSD is the ability to rely on friends, family, and community to prevent isolation and distract the victim from their trauma. A lack of social support is detrimental. Furthermore, if a victim's social network blames them for the trauma, it adds to the feelings of distress and guilt. Blame can be outright or more subtle, as with secondary victimization. Victim blaming was a common occurrence with veterans of the Vietnam War and happens often to victims of rape who are often not believed or blamed for their assault. According to Ehlers and Clark's cognitive maintenance model, PTSD is maintained through negative appraisals and disruptions in autobiographical memory that create a current sense of threat. This model explains and is consistent with clinical symptoms and provides a framework for what to target during treatment. People with PTSD have many comorbidities and some of the highest rates of healthcare service utilization, further stressing the importance of effective diagnosis and treatment. For pharmaceutical interventions, the FDA has only approved the use of selective serotonin reuptake inhibitors. SSRIs increase the brain's concentration of fear and anxiety neurotransmitters by blocking their reuptake from the synaptic cleft. Marshall et al. Compared the SSRI paroxetine in a dose of 20 milligrams per day and 40 milligrams per day to a placebo treatment and found that both treatments showed greater improvements in PTSD symptoms over the placebo. There is a much larger array of psychological therapies to treat PTSD, many of which revolve around engaging with the trauma memory or trauma-associated stimuli. One such intervention, prolonged exposure, or PE, stems from emotional processing theory and is built upon the notion that symptoms are maintained by avoiding trauma-related stimuli. PE works to stop such avoidance by creating new associations through gradual exposure, processing of the trauma memory, and learning skills to cope with distress. Exposure can be in vivo, engaging in avoided situations and activities that are not actually dangerous, or imaginal, repeating the trauma memory aloud in great detail and listening to it. One non-trauma-focused psychological therapy is present-centered therapy, PCT. PCT involves no exposure or cognitive structuring, but rather focuses on maladaptive relationship patterns and behaviors that have emerged as a result of the trauma. Psychoeducation is used to show the patient how the trauma has impacted their life and teach them problem-solving skills to better cope. In a randomized controlled trial, Schnur et al. Compared PE to PCT in female veterans with PTSD and found that women receiving PE had a greater reduction of PTSD symptoms and were more likely to reach total remission by no longer meeting PTSD diagnostic criteria than those receiving PCT. Given that avoidance of trauma stimuli is a key symptom and maintaining factor, it is not surprising that confronting such stimuli is an integral part of the treatment process. Another non-exposure-based intervention is cognitive processing therapy, or CPT, which is a brand of cognitive behavioral therapy. It focuses on changes in thoughts, feelings, behaviors, and bodily sensations resulting from the trauma. CPT provides an understanding of the disorder and reduces distress to improve daily living. Monson et al. Showed that CPT led to significant improvements compared to a waitlist group. One of the more controversial therapies is eye movement desensitization and reprocessing, EMDR. In EMDR, patients recount or think about their trauma memory while paying attention to the back and forth movement of a light or sound until the distress associated with the memory eases. The controversy stems from the eye movements and whether or not they are relevant or just an accessory. In a meta-analysis of 34 EMDR studies, Davidson and Parker found that EMDR was more effective than no treatment or treatments without exposure to trauma-related stimuli, but was not significantly more effective than other exposure-based techniques, meaning that the eye movements themselves produce no effects and are therefore not important to treatment. The most important part of psychological treatments is exposure to trauma-related stimuli or memories. There are also several less common supplemental treatment interventions for PTSD. The VA is currently running the first randomized controlled trial on the use of service dogs in conjunction with psychological treatment for mental health conditions. This particular study is looking at the effects of service dogs and emotional support dogs on daily life functioning and PTSD symptoms. Art therapy is another adjunctive treatment that is sometimes implemented for PTSD patients. Art therapy uses processes of creating art to facilitate emotional healing, promote self-worth, and allow patients to non-verbally communicate their thoughts and feelings. A randomized study by Lyshak Seltzer et al. Showed that the trauma-focused expressive art therapy group showed a greater reduction in PTSD symptom severity than a treatment as usual group. Although PTSD is a well-studied disorder that has numerous efficacious treatments, there is no cure, leaving room for further research. Furthermore, even though efficacious treatments exist, they are not always reaching those in need due to misdiagnosis and continued stigma around the disease. Improving treatment accessibility and reducing the stigmas of PTSD could help increase treatment, improving the lives of those that suffer and minimizing the economic burden. New technologies open up additional avenues for PTSD treatment and offer the potential for advancement. The VA created a PTSD Coach mobile app that helps users learn about, manage, and track their symptoms and learn about treatments and coping skills. Virtual reality is starting to be implemented in exposure-based treatments to realistically expose patients to triggering events rather than relying on their imagination and memory. A team at the University of Southern California has created virtual exposure therapy for Iraq and Afghanistan veterans. Lead researcher Dr. Rizzo notes that even if the VR worlds are not perfect replicas of reality, they provide a close enough representation that the brain will fill in the missing details and patients will experience them as accurate. While engaging with VR environment, patients talk about their experience with the clinician mirroring the traditional exposure psychotherapies, but in a way that may be better suited for a generation that has grown up in the age of technology. The current progress to understand the causes, maintenance, and treatment of PTSD and the foundations laid for research and improvements suggest a more promising future for those diagnosed with PTSD.